All right, guys, Sarel Gaur MD. Today we're going to talk about how to read cases quickly and accurately. So let's just talk about some basic rules here. So rule number one for me is get to the point. Get to the point. That is kind of the most important thing. As soon as you open up a case, try to figure out what is the point of this case. Keep asking yourself that as you're getting more and more involved in the case, keep asking yourself, what is the point of the case? Keep redirecting yourself, because as soon as you lose sight of that, you are very prone to kind of getting bogged down with details and kind of creating a long, uninteresting report. So don't let that happen. Keep telling yourself, what is the point of this case? You got to figure out what the narrative is that supported the ordering of that case. Now, every patient basically has a narrative, has some sort of a story that has led them to seek care, and you need to try to figure out what that is. Now, easiest way to find this nowadays is really just the medical record, which you should have access to. So often I'll just pull up the electronic medical record and start from there. For example, I might be reading an outpatient CT ordered by a surgeon. A lot of times I'll open up that surgeon's note, and right at the bottom of that note, it'll say something like, I'm suspicious for a hernia. And so then I know the point of that case is looking for a hernia. So I can very quickly scan through that case, probably about 5 seconds, and decide if there's a hernia there or not. And there you go. You have created the work value of that case right there by just looking up the narrative. And again, you can just save a lot of time, and you can use that time to finish up one case and then start working on the next case. How can you help the next patient and the next patient and so on? So priors, make sure you're checking priors. We're supposed to check priors, but I know for a lot of different reasons, sometimes people don't check priors. But one thing that is annoying about pulling up priors is, you got to wait for them to load. So often I'll open up a prior, wait for it to load. I'll actually read the report, because often the report's available. I'll just start reading the report of that prior as the prior is loading up. And again, what the prior does is, again, it starts to create a narrative for you. It kind of tells you. Now, again, the interpretation could have a bunch of errors in it itself, or it could be a misinterpretation, but at least that interpretation tells you, what did a physician, what did a radiologist think then? What did they think was going on then? And how do I translate that into what's going on now? How can I build upon that? Are there some interesting diagnoses that are already listed there? Is there a known diagnosis of cancer? Is there a known diagnosis of liver disease? Is there known end-stage renal disease? Again, this will help you not be surprised when you're looking at the current study and what's going on. And then once you have a prior study, especially if you have a recent prior study, you've got to realize that you don't want to reinvent the wheel. If you're looking at a current study and the prior study was, say, a couple days ago, you don't have to relist everything out again. You have to basically talk about the change. And if there's not a huge interval change, then that is the diagnosis. And again, I'm not saying that you always want to diagnose or write no interval change. What you want to do is start thinking about, what is the interval change, and what am I really looking for? What's the real point of this study? And it might be something subtle. It might be something that, if you look for it, you'll find it. And now you can expand on that, and that can be the point of this study, rather than just kind of creating another long report with a lot of noise in it. For example, CTAs. I used to read CTAs in residency, and it would take me like 1 hour to read an entire CTA. And you just sort of have to understand, what is the disease process that you're looking for. Now I'll open up a CTA, and I'll open up the vascular surgery note, and I'll see right there they're suspicious for, or they have right leg claudication. And as soon as you open up the case, you can quickly scan the vessels, and you might just see right there, and this has happened multiple times for me, I'll just see that the SFA is out, or the SFA has a big lesion in the mid portion. And that is pretty much what 90% of the case is just diagnosing that and putting that out there and making sure the clinician sees that. And again, doesn't mean that you don't spend time on the rest of the case. You'll spend time looking for other things. You'll look below the knee. You'll look at the visceral arteries. But really, as soon as you kind of put together, again, the clinical context with an imaging finding that's well demonstrated on a good quality CT study, you have created the value, and you want to lead with that. Put the value into the dictation and send it off. And again, another way I try to sometimes add value and actually decrease my time too, and I think decrease my liability, is I'll send electronic messages. I use the electronic chart to my advantage. Send an electronic message. It's logged. It's saved. You can tell. It's sort of time-stamped. You can tell when someone accesses it. So again, if it's an important finding, I don't do this for things I'm supposed to call on, but for things that I want to make sure they get a receipt of that information, I'll just send an electronic message. Okay, guys, rule number 2, ditch templates. Get rid of templates. Now, there is one caveat. For normal studies, which of course right now or going forward, there's going to be a lot of normal studies. For normal studies, it's okay to use a template. I think it's actually preferred to use a template. So for normal studies, I'll often just have a nice normal template ready to go. And as soon as I figure out that the case is normal, I just hit sign right on the mic and move on to the next case on the list. But for studies that aren't normal, and especially for studies that are frankly very abnormal, it's definitely best to just delete the template and just start from scratch. So oftentimes when I see multispatial disease, a multifocal disease, or a diffuse disease process like cirrhosis and all the sequelae, I'll just clear the template and just start dictating right into the mic and just speaking out the findings as I'm seeing them, and actually just trying to make sense of them as I'm speaking them into the mic. So on this subject of templates, so actually as a resident, I used to get concerned with actually things like cirrhosis, because I'd spend a lot of time, I think I'd say I'd wasted a lot of time. I wasted a ton of time actually just thinking about where to put each of the findings into the template. And this is why templates kind of have their issues, have their problems. I spend a lot of time deciding, okay, ascites, where do I put that in the template? Is that going peritoneum, or do I list it with the liver? Or the varices, do I put that in the vessels section? Do I create a new section? Do I list that with the liver? If I see an HCC, do I talk about that with the liver? Do I create something new? Where does the portal vein thrombosis fit? And again, a lot of wasted time, a lot of time spent thinking about where does this disease fit into multiple compartments when sort of disease is often multispatial. So I think just think about it and talk about it in a multispatial way. And then if you really do want to organize something, I think spend some time organizing your thoughts in the impression. You can use the impression to really kind of decide in a ranking order, what's the most important finding and what are the least important findings, and just talk about them right there. For example, sometimes I'll see that, a patient has a new HCC with portal vein thrombosis. So that'll become line 1. And right there, you have created value, and you've done it by just, again, thinking about the case and just dictating, speaking right into the microphone, the important finding as soon as you see it, and putting it right into the impression. So rule number 3 is, focus on getting the big things right and letting the small stuff slide. And this is kind of a difficult thing. And this is something that gets a lot easier with experience and just seeing thousands and thousands and thousands of cases. A bigger report is not always better. A super long, super detailed report with a lot of measurements and a lot of image numbers is very dense and very difficult to read. And unfortunately, it's just going to fall on deaf ears. It's just going to get produced and it's going to get printed into the electronic chart. And unfortunately, people just aren't going to read it. So don't bother creating that. And a lot of this just comes down to, what is your job as a radiologist? Now, in training, we're taught to kind of look for things, and we learn to look for things, and we learn to find small things. And sometimes people might make the mistake that the job of the radiologist is to find a bunch of small things. And I don't think that's true. I think our job is to kind of integrate things, boil things down, and make a useful, actionable report. So for example, I know that we see a lot of renal cysts, and I know that sometimes we see hyperdense cysts. So if I see, 5 or 6 hyperdense cysts on a 75 or 80-year-old patient, I don't think it's my job to measure out each cyst and then measure the Hounsfield units and attenuation, and to then suggest a MRI renal protocol or MR of the kidneys on every cyst that doesn't fit the criteria. I don't think that's the goal. I think the goal is for me to say there are some probable multiple hyperdense cysts which are stable to previous studies, and just kind of leave it at that. And then again, focus my energies on the bigger picture. For example, I was reading a follow-up case on a patient that had a ablation, and I read the oncologist notes, and they were doing a repeat study to just see if they needed to do any more localized treatment. And I could see clearly that there was multiple nodules. All of them had progressed. The ones that had been ablated had also progressed. And I realized that was the point of the study, is just to say that despite these localized treatments, the majority, basically all of the disease had progressed, and progressed significantly, like large centimeter increases in the size of these tumors. Now, I could have gone through and listed out, of the tumors in the liver, which I believe there were maybe 7 or 8. I could have described each lesion, the location, the segment number, the size increase. But again, what's the point of that? What's the point of that? The point of that study really, again, to me, in my interpretation, and based on creating a context and a narrative with the oncology note, the point was to see if these localized treatments had in any way kind of stopped the progression of the disease. And my impression was basically that, unfortunately, in light of these localized treatments, this disease is progressing everywhere. So potentially need to try something different. And in actuality, that patient is probably going to go on and try something different, potentially a more diffuse liver treatment like, say, Y90. So again, that's kind of how you make a clinical difference. It's about experience. It's about just seeing a lot of cases. And it's about just creating that clinical context. The more experience and the more things you see in the healthcare setting, the more kind of important and actionable and useful your reports become. And I think that definitely, to read fast, to read accurately, you need to kind of go through all those things. So hope you guys enjoyed this video. If you want anything additional, there's a lot of different tangential things I could talk about, and feel free to let me know in the comments. Sarel Gaur MD.